Good afternoon and welcome to Bariatric Friday. Today is February 2nd, 2024. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's great to be back on yet another wonderful Bariatric Friday.
Absolutely. So, well, every day, that's what we do, right? So we start the day with bariatric and finish it with bariatric. So our goal is to provide most support, extra support for our patients who are going through the process, and also for those who may be dealing with morbid obesity. Also, we want to be another channel for them to actually learn and understand what morbid obesity is and how it's treated. That's why Dr. Irgau is one of the most experienced surgeons in the bariatric field. He's with me, and everything that you hear from us is coming from a clinician. So we try to take the process in different topics and then try to provide these informations for our patients. So just to kind of maybe recap, Dr. Irgau, on the qualifications, I say qualification just because that's what we have been using in the industry, but who are able to actually receive the surgery. And then we'll start with our topic for today for the care coordination part of bariatric surgery.
Absolutely. So as you said, bariatric surgery is a treatment modality for excessive weight that has gone really extreme. And we do have very clear guidelines as to who benefits the most with the surgery, right? And currently our guidelines are that a person has to be at least 100 pounds over their ideal body weight to be candidates for bariatric surgery. And that essentially means that if a person, for instance, if they are 5'5" in height, and we say that their ideal or healthy weight is, let's say, 150 pounds, if that person gains weight over time, and now their weight is 250 pounds, it means that they are 100 pounds over their ideal body weight. That is the point where we trigger bariatric surgery as a potential treatment for that person. There is another way to quantify that, and that is to talk about body mass index, or BMI. That is a calculated number that puts into account the height of the person and the weight of the person. And if that number is 40 or higher, then that person is a candidate for bariatric surgery. Sometimes even a body mass index lower than that, let's say 35 kilograms per meter square or higher, can make a person a candidate for weight loss surgery or bariatric surgery if that person has also developed certain illnesses that are commonly associated with excessive weight, for instance, type 2 diabetes or high blood pressure or sleep apnea. A person can calculate their body mass index by going online. For instance, they can go into our website at crias.com and they can actually put their height and their weight, and it will give them their body mass index to see if bariatric surgery is something that they can look into.
So, Dr. Irgau, we categorize bariatric surgery one of the most efficient tools to fight morbid obesity. Of course, there are other ways to actually lose weight, but our patients in the category of morbid obesity, and this is a different level, are there some miracles? Yes, we do have some miracles. There are some patients, maybe 1 in 1,000 or 1 in 10,000, they may be able to lose weight by diet and exercise, but it's not the case for most of our patients. And yet still it's only used by 1% of these who are qualified to have this surgery, knowing that this is the most efficient way to do it. That's still very underutilized. So for those who don't understand morbid obesity, and like whether or not this is a chronic illness, if there are two patients, one with diabetes, the other one is with morbid obesity, which one do you give the drugs first? Because one of them may not be still categorized as perception may still not be the chronic illness. So can we just talk about that a little bit?
Absolutely, absolutely, Kamal. It's interesting that even the history of morbid obesity as a disease within the medical community is actually recent, right? There was a time in which doctors did not think of morbid obesity as a disease, but they thought it was something that was brought on by people onto themselves, and that they could lose the weight. They just needed to diet and exercise. Well, as obesity increased in its prevalence in our society, in fact, over the last 30 to 40 years, it has gone much, much higher levels everywhere in the United States. So that even 30% of the population actually is either overweight or obese in the United States currently. And with that, obviously, it increased the prevalence of things like type 2 diabetes and high blood pressure. So doctors were suddenly faced with a situation where they were seeing patients struggling. And the question was, why are they not able to lose weight? Why are people not just diet and exercise and then they're not losing weight? And the first thought was obviously, they're lazy. They don't have the willpower. And yet when you dig into it deeply, you can see that even people with the highest level of willpower, people who can achieve many things that they seek after in life, whether it's in their job, in their professional life, in their education, those very people also struggle with weight, right? And then clearly the medical establishment came to understand that there is something biologic that drives weight. It's not just about willpower. And there is a pathophysiology, there is a disease process behind it, just like high blood pressure, just like diabetes, or even cancer, right? It's a chronic disease driven by biology, facilitated obviously by the environment, obviously, in which we live, where there is high availability of cheap calories and less options and opportunities for people to be physically active. That combination has really created this epidemic. It's a true epidemic, and it's a disease. So to tell somebody, oh, you have obesity, go diet and exercise, is unacceptable nowadays. We have to accept that it is a disease. And when it reaches certain levels, Kamal, it's almost impossible to lose weight with your own means, right? As you said, yes, there are some people who can achieve that, but those are rare exceptions. And we cannot guide ourselves through those rare exceptions. We have to look at the population at large. And now, currently, the most effective treatment we have is bariatric surgery, and it has been recognized universally. Primary care doctors routinely refer and recommend or counsel their patients to look into bariatric surgery as a solution. Now, we know very well it's not a magic answer, meaning that just because you have bariatric surgery, now you free yourself from morbid obesity. Far from that. It's a biologically driven disease, which means that that tendency will be there as well. So alongside bariatric surgery, it's critically important to adapt a healthy lifestyle with how a person eats, when they eat, what they eat, but also how active they are physically. So bariatric surgery has to be incorporated with a change in lifestyle that will guarantee that obesity never comes back in that person's life.
Absolutely. So one of the main elements of bariatric surgery from our program standpoint is our care coordination. And you and I, we work together to develop this care coordination part of the bariatric surgery process. And as we have done this in different facilities, we didn't have full freedom in some of these hospital facilities. And once we have our own facility at American Surgery Center, then we decided that, okay, we have to do this in our way. And our way was different than the way that we were doing before. So I would say since 2018, since we started the bariatric surgery process in the surgery center, now we are doing it differently. So this biggest difference is we have our nurses assigned to our patients, so they have designated person to deal with. And not only they are just being coming into the program and mentioned only once, but they are patients are part of the program every day. Every day they have follow-ups and different things that they have to do. We actually hold hands with them and make sure that they get the most support, because we know that during this process, one of the issues that we deal with is the fear. One of the issues that we deal with is the social stigma and peer pressure and all those other things that's happening while someone is trying to get ready for the procedure. So the best we could do is to put designated resources, and with our daily case conferences, we are able to keep our patients in the program. That's why we have one of the lowest dropout ratio, and this is working out so far. So let's actually talk about the different parts of the care coordination. If you can actually just start the process, and then I'll join you.
Absolutely, absolutely. So as you correctly said, care coordination is critical, right? And why is that? Well, because we have long recognized, Kemal, that a multidisciplinary preparation of the bariatric patient leads to better outcomes, right? Better outcomes in terms of long-term weight loss, in terms of compliance, in terms of improvement of health conditions related to obesity. But this multidisciplinary preparation requires a coordination, right? And the care coordinator team, like the one we have at the American Surgery Center, is like the central nervous system of this, right? It really guides the patients through this process, which can be very difficult to navigate if you don't have enough knowledge of it. Obviously, patients come to us naive. They don't know all the ins and outs of the preparation. We are the experts. Now, providing information is one thing, but it may not be enough. You have to be able to handhold the patients and help them navigate the system so that they can easily interface with the different members of that multidisciplinary team without really prolonging the process unnecessarily. And that's what the care coordination is very important. Now, this central nervous system of our program, which is the care coordination team, has to meet on a very regular basis, right? And ours has the highest frequency of meetings, as you correctly said, anywhere in the country. We actually meet on a daily basis. That's almost unheard of. And who do you have in that? You have, the chairman yourself. There is myself, the clinical director. We have the nurses who are the assigned care coordinators. We have the people in charge of our bariatric center, of the surgery center, and we have the people in charge of our office CREAs. So all the stakeholders that see the patients navigate through them are present. And then we discuss each patient one by one. So where is that patient? Well, they've just started the process. Well, do they have enough orders for them to go to the places where we want them to go? Do they have enough information to go to the appropriate specialists that we have referred them to? Is that close to where they live? Do they have enough time off in their jobs to do it? What kind of times are available in their job for them to do this? This granular follow-up can be undertaken only if the care coordination team is meeting on that regular basis. And it's no wonder that we have one of the highest follow-up rates as a program from starting the program to actually undergoing surgery. And that is because of that care coordination. So that care coordination, Kemal, is absolutely critical in maintaining the integrity of our multidisciplinary program. And the multidisciplinary program also, alongside the experienced surgeons, guarantees that excellent outcomes with lower complication rates and with long-term follow-up that we are able to attain in our program.
So a patient has to go through so many different clearances that we mentioned.
Yeah.
So just so that we can start what they have to do, they have to start with the nutrition classes first. So the nutrition probably is one of the most important parts, because we want them to learn how to deal with the surgery prior, and also we want them to learn new skills to take care of themselves after the surgery. So nutritionist, dietitian's job is one of the most important one. So we want them to start with that. Then there's always blood work that needs to be done, and we would like that to be done as quickly as possible. So this way we'll know whether or not they may need any additional follow-ups. For example, if they have diabetes and if their A1C is over 8.5, we may ask them to get an endo clearance, or if their TSH is over 5, we may ask again for an endo. If there's any hemoglobin issues, we may ask for hematology. So those things need to start right away. So then we have the cardio clearance, which usually is in 2 different segments with one first initial visit. Then they may need to do an echo or a stress test. Then they need to get their home sleep study first, so then we can decide, we can diagnose whether or not they have sleep apnea. They need to get their EGD done. So the EGD is important, so then we can actually understand whether or not, let's say if they are going for gastric sleeve, and then they have Barrett, then they may need to actually change to gastric bypass. And then they need to get site clearance, which many people who are not really familiar with the process, they don't understand all these clearances. And we'll talk about why these are important and how this is different than any other surgical process. And also we do ask for a bariatrician, or maybe in some cases from their primary care. And while they're also going through their surgeon follow-ups. So there are so many different things that they have to do. And yet also we make these videos available so they're able to actually get familiar with some of things, because time may be limited. So this is where the assigned nurse, designated nurse would be the most helpful. So now, if we were to take it, Dr. Ergau, from the EGD, where we see some additional work that needs to be done, if you can kind of maybe elaborate that piece, and then I'll explain the side part of it a little bit.
Absolutely. So what is the EGD? An EGD essentially is the esophagogastroduodenoscopy. It's an endoscopy. It's a procedure whereby we are able to examine the inside of the food pipe of the stomach and the upper portion of the intestine to make sure there is no disease process that needs to be addressed before bariatric surgery. Because when we do bariatric surgery, whether it's the gastric sleeve, the gastric bypass, or the duodenal switch, we are doing surgery on the upper digestive system, right? And knowing beforehand that there are issues that need to be addressed is important. And sometimes there may be findings that actually will direct the type of surgery that may be appropriate for that patient. As you know, for instance, if we were to discover that the person has Barrett's disease, as you know, we would generally recommend going with the gastric bypass as opposed to the sleeve gastrectomy. So it's an important evaluation. And but it does require coordination, right? The person has to be scheduled. They have to go to our surgery center. They have to be evaluated by anesthesia. They have to take time off. So all that requires coordination. And yet that is only one part of the preparation that is needed before bariatric surgery. And look, from a patient's perspective, Kemal, we know that when patients first think about bariatric surgery as a possible solution for their weight, they reject the idea. They think, you know what, yes, it's not for me. I can do it by myself. And on average, it takes about 2 years before somebody comes to terms with the fact that, yes, bariatric surgery is an absolute necessity for them. Once they make that decision, they want the surgery the next day. They want it done immediately, right? So when they come to consultation, as they are really ready and mentally prepared to undergo bariatric surgery, and they wouldn't mind to be scheduled, for the surgery for the following week. So when we tell them that there is preparation, it takes some understanding from their side. But it is important for them to understand that one of the reasons we have made bariatric surgery one of the safest surgeries performed currently is because of this thorough preparation that we have to undergo. Bariatric surgery, in a way, had to prove itself as a very important form of treatment because of the stigma attached to obesity. And bariatric surgeries were looked upon not as legitimate many years ago, Kemal. So because of that scrutiny, bariatric surgery had to really prove itself as very, very safe. And it is really mind-boggling when you think about a sleeve gastrectomy has the same levels of safety as a gallbladder surgery or appendix surgery, right? And we are able to do that because we have this optimized preparation that goes through this extensive preparation. So when we do endoscopy, we don't want to be surprised by a finding at the time of surgery that may increase the complication rate or lead to aborting the procedure. We want to be prepared, and doing the endoscopy helps us to do that.
Good afternoon. Welcome to Bariatric Friday. Today is November 4th, 2022. It's another Friday. My name is Kemal Erkan. I'm the chairman of American Surgery Center, and I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Thank you, and welcome everybody to another Bariatric Friday.
So this is our journey for 3 of our patients, and I want to bring them up. All right, so Karen, Denise, and Patrick. Well, of course, these are, I should probably mention that in every video, they are not real names, but they are real patient data. In our Bariatric Friday, as everyone knows by now, we are discussing each topic as a unique or just independent topic from rest. So we do have our webinars. Our patients can register through our website, where we actually go through the entire process all together. But in many ways, it's much easier to process this one by one for different parts of the bariatric process. So today we are going to discuss the care coordination and the impact of care coordination. Why do we need care coordination? What are the different roles of care coordination process and all that? Dr. Irgau is going to help me with that, right, Dr. Irgau?
Absolutely. I will, of course, come on, but as you know, that is an area where you are yourself heavily invested because you do conduct those case coordination conferences on a daily basis. But most importantly, you were critical in really setting them up and providing them structure, not only in terms of getting the right people in the right place, but also having a database that is so effectively useful for us.
So we build that database just going back to year 2012. This was something was done through some Excel file when we were in the partnership with the local hospitals. And from that point, I knew that it was not working for us because coordination, although it's done through, it's done by our people, coordination requires a strong platform so that we can actually follow through what's started and who's where, what's missing, what's not. Now, our patient population, each of our patients, they have different levels of needs from us. Now, knowing that this is a multidisciplinary, many bariatric programs are similar to what they need from in terms of the clearing than others, but we are very unique in terms of the approach to the care coordination because we do have about 5 nurses and 4 administrators, a surgeon, 3 dietitians, facility, the American Surgery Center, they're all part of it. And one of the uniqueness is we do this every day. In the past, this was, and in many places, this is either happening maybe once a month, only for some new patients. And it's not, the patient process not being discussed, maybe, in my opinion, properly, because what I have seen in our patient population, things can change from week to week. So if we are not doing the hand-holding, many patients may be lost in the process. So even for some simple procedure, we know that instructions are so important. So if you don't mind, and I won't give names, yesterday I had a procedure that was canceled because I was chewing gum. So I read 2 full-page instructions, and nowhere in that instruction did it say that I shouldn't be chewing gum. Prepping for the procedure and going through that entire, like even though it was only 1 day diet, after the 24 hours, you are pretty anxious and you are pretty hungry and cranky. As soon as I was told that the procedure couldn't be done because I was chewing gum, my initial reaction was, it wasn't on the instructions. Because instruction says when I should do X, Y, Z very much in detail, but the chewing gum is not a food. Gum is not food. It's not drink. So then, and I own a surgery center, so I would know if this was going to affect something, right? So that wasn't the case. It's a simple. Then as soon as what I told Dr. Irgau, we didn't talk about this, that we were going to actually discuss this in this way, but I thought it was, I always try to kind of understand patient where they are in terms of how they process certain things. And one of the things that we do is this special diet 2 weeks prior to the surgery. And when we don't actually do the care coordination properly, that 2 weeks can be very painful if the patient doesn't get the surgery done. And as soon as I was told no for my procedure, I thought about our patients who are going through this for 2 weeks. And then it made it even more important for me to value the service that we are providing, because this is meaningful for them. So, because even something very small can change everything.
Absolutely. But this is a great example, because really, as somebody who is involved in caring for these patients, now you've had a personal experience that gave you even more what the patient's perspective is on this issue, right? But what I was thinking, Kemal, and you didn't say that, is, it would have been a lot easier for you also to either cancel or postpone, right? Whatever the medication or the treatment was, right? And look at that from a bariatric point of view, right? It takes enormous effort for patients to make a decision to undergo bariatric surgery. And we know that because we know that only 1% of those who actually are eligible for bariatric surgery come forward requesting bariatric surgery. So the 1% that is coming forward are the ones that are making a lot of effort, that are going against the grain, so to speak, of what they hear and what they're told, or how they are perceived because of morbid obesity, and they're taking the step, right? The last thing we want to do is giving them hurdles and obstacles and making it hard for them, right? Well, when we are requiring patients to undergo so many clearances, in other words, so many appointments, so many tests, unless we provide them with intense coordination like we have set it up, it becomes very easy for patients to drop out. In fact, it is not surprising, Kemal, that in most programs, the dropout rate is way, way higher than our program. And that is because patients are discouraged, right? And the discouragement happens because patients may be given a set of instructions and told to get it done and then come back without really somebody checking on with them either by text messages or by phone on a regular basis to make sure that they are succeeding in getting these appointments done. So care coordination may not be the surgery, but it's a critical part of our program. And I'm extremely proud actually to be part of this team, Kemal.
So if we were to, and I was kind of trying to see these as if the patient is watching this, so what we want them to know. One is you are going to be assigned to a care coordinator. So you are going to be dealing with one person. Not only they're in charge of your follow-up surgeon appointments throughout the process, but they're also helping you with your specialist appointments. So these specialist appointments, it can be your EGD with the facility, your cardiology clearance, your home sleep study, bariatrician. And based on the blood work that you do, the patients do, we may need to repeat some of those studies based on the values that we have. And having that one point of contact is extremely important from that point. So then you know that it's always going to be one person that you have to deal with. Now, the beauty is we actually talk every day for 1 hour, and your case is being discussed in that. So I run one of the 2 case conferences, Melissa Demat, our program practice administrator, and myself, we have 2 teams and we rotate those teams every 2 weeks. So then we have some familiarity with the patient, so then when we follow up, we are not missing anything from 1 week to the next. And then we actually, our nurses, they report back to us, and then what's needed, what's not. Facilities there, Dr. Irgau is there. Our nutritionists, they join us once a week, and then they report back to us. So once we know that the patient may need more studies, in some cases, cardiac clearance requires a certain test and maybe another follow-up. So all those appointments are done in the same system. So that actually is a huge benefit if we are able to keep the patient in one network, so then we know when your appointment is. Once they are done, we don't need to actually call anyone to get the results or get the notes. This makes it very effective and efficient. And I know that our drop rate, actually, the other day we were just looking at it. So this is why our drop rate ratio is very low compared to the other programs or the industry standards. So what else we want to?
So essentially, yeah, absolutely. So the important point also, Kemal, is that patients have real lives, right? They have jobs, they have commitments to their family, they have children. The time is also very limited, right? And they may not very often be able to do things that we ask them in a timely fashion, even with the support of the care coordinators, right? If we are not able to find that out in a timely fashion, reach out to them and say, hey, you were not able to do your blood work, right? You need to do it at this time, or you were not able to come to your appointment with the heart doctor. We need to reschedule that. If we don't follow up in that manner, then it is very easy for the patients to throw up as well, right? So I know from our system, for instance, you have the ability to communicate in real time with patients, either by a phone call from the case conference itself, or by sending an email, specific email, talking about what the issue is. For instance, if it's the lab work which is missing, the email will target that. If it is the sleep study, the same thing. So by doing this, we're actually supporting the patients in doing this fairly intricate process, understanding that they have a real life as well. And I think this is enormously important for our patients. So the requirements are there, right? Everybody has to go through a number of appointments to be able to prepare for bariatric surgery properly. Of course, there is what we call the medical checkups and medical clearances, and that includes, being seen by a heart doctor, for instance. But it's not just an appointment with the heart doctor. As you know, they may require something called an EKG. They may require something called an echocardiogram. They may require something called a stress test, right? And all that will require coordination. We may need to send them for a sleep study, for instance, if there is a suspicion from the surgeon that the patient may be suffering from sleep apnea. The sleep study by itself requires coordination. Getting the sleep study result, and if the sleep study result is positive, patient may require a CPAP machine. And that CPAP machine needs to be ordered specifically by a pulmonary doctor very often, but the CPAP machine itself may have to come from a different company. That requires coordination. So the pair coordinators are just so critical in facilitating all that. And in our actually practice, we have been in a way lulled into be comfortable with this, and our surgeons actually have taken this for granted. But in many other programs, actually, there is a lot more struggle that goes on because patients are not really able to do that. And there may be other things. You mentioned the endoscopy, for instance. EGD is endoscopy whereby the patient is asleep with a very light anesthesia, and then we put a camera down the food pipe into the stomach and early intestine to figure out to make sure there are no problems that need to be addressed before the surgery. It's an important component of our preparation, and that requires coordination as well. And then there may be other things like going to see a hematology, a blood doctor, for instance, if the patients have problems with their blood count, or if they have a history of blood clots. So all that preparation obviously is necessary, but it requires coordination, and that's where we excel with our care coordinators and the case conferences.
So now, for example, in the case of Patrick, so we had to reschedule the EGD twice. he has to reschedule the EGD twice. And it's one of the main elements of the clearance. Without the EGD, we don't move forward. And his work schedule, when you were saying that these are real people, they have real life, right? So then if someone is not able to do it, so the care coordinator's job is to figure out when and how we can actually make some adjustments so that this person can get the EGD done. So just because they have two rescheduling doesn't mean that we are going to give up on them. Absolutely. Now, he also had a follow-up with the endocrinology because his TSH originally was 7. So, and then getting that endo appointment is challenging because if you call any practice today, that's going to be 3-4 months. So based on the surgery process, we would be actually expediting those appointments because we work in this multidisciplinary system. So same thing with, I think, Karen, her A1C, if I'm not mistaken.
Yeah, she is diabetic. I do remember that when we first introduced.
And I think that Denise also is. So then they need these endo appointments. Denise actually, let me just go to Denise for a second. So she did have her hemoglobin was under 10. So then this requires another attention. So I think what we want our patients to know is we build this machine in a way that platform that actually takes care of all the needs before you get to the surgery so that there is no missing link between you and your surgeon and your surgery at the end of the day. So because this hemoglobin can be, as for females, it can be like not so important based on certain biological differences, but it's under 10, we still need to find out why. So, well, you don't have to worry about it. So as a patient, or you don't have to wait for our next surgeon visit. So this is what the care coordinators are doing. Absolutely. So then the endo appointment, you don't need to discuss this with the surgeon while you are waiting for the appointment because we'll be able to get in your appointment to get you ready and then repeat the test. So then when you go back to the surgeon for follow-up, you have meaningful visits because your surgeon has everything that he or she needs to have to make the moving forward decisions. So the sleep study, the home sleep study is a very simple test. And I think not just for the patients with morbid obesity, but everyone should actually take the home sleep study at least once because sleep apnea is, if it's not treated for long term, it can create cardiovascular issues. It actually goes to a different level. So it doesn't stay on its own and then you just have the sleep apnea. That's not the case. It actually evolves and it becomes something else or something more severe. So that's why everyone should be actually getting it, but especially our patients. But it's done in a different place, but we already have everything ready for you to get this on time, and then the follow-up from the DMU company is also coordinated with our care coordinators and with the practice. So this makes it a lot easier. So then, because I can only imagine, and especially like going through a very small procedure and then trying to read the instructions like a couple times, I probably have more appreciation for that needs to be done, right? So then you understand that you can't miss anything, or if you miss something, or if you have questions, what is next? Those are all important things, and then care coordinators will make this easier. So what I was trying to say is that it makes it sometimes it makes it a little bit cumbersome when you tell the patient that they need to go through all these things. Well, they're not that cumbersome when you have a full-time care coordinator with you. And one of the things that also we do in terms of total number of bariatric surgeries, we actually do less than what we used to do 4 years ago, just because we want to spend more time with our patients, more quality time with our patients. So we don't want to have like 100 patients and then 70 of them dropped in 3 months. We want to start with 65 patients and then 50 of them are going through the program. So this is what we have built for our patients so then they can actually safely get to the time of the surgery. And also these care coordinators do schedule their after surgery follow-up appointments up to 5 years. So
Absolutely. And the other point that is very important, that is much more clear to the surgeon, is what happens on the back end, right? What happens in the back end is that those care coordinators are also a bridge between the test results and the surgeon himself, right? So they are able to look at these test results and send them to the surgeons, so the surgeons can look at them and act on them in a timely fashion, whether it is a test result that requires referral to another specialist, whether it's a test result that requires further testing, or whether it is a test result that requires discussion with the patient, right? So that timely information to the surgeons also is enormously important, because obviously minimizes the wasting of time, but also it's very good for the patient also, because if there is something abnormal, the patients will want to know about it soon, and they will want to know that it's being taken care of in a timely manner as well. So the back end work of the case coordinators, following up on a daily basis, what's happening with their patients, and then communicating that to the surgeons also is enormously helpful to us. One issue that I would like to bring about, Kemal, and that's very important, is that we've started talking about, Karen, Denise, and Patrick almost, 2 months ago or 3 months ago, right?
2 months.
2 months, right? And they still haven't had their surgery, right? And the reason is also because of this preparation period. And patients may wonder, why is this all necessary sometimes? Well, it is necessary because bariatric surgery is a life-changing surgery. It's not like other surgeries where you have, an ailment, a hernia, that the surgeon takes care of, and then you go back to your primary care doctor follow-up. With bariatric surgery, we're actually changing the way a person lives in terms of how they eat, how they perceive food, how active they are going to be, what kind of health problems they're going to be confronted with, and all that requires a preparation, not only physically, but also mentally and emotionally as well. And that requires interaction with a number of disciplines and specialists, and navigating that intricate process is really helped and set up by our case coordinators. So we excel at that, just as we excel with the surgery, because we're so much experienced with the surgery as well. So a solid program with a solid case coordinating setup and experienced surgery is really what gives our program uniqueness and excellency.